Bismillahirrahmanirrahim. Today we are going to learn about the Pagets disease, and these are the references for this video. At the end of this video, the first year MBBS student should be able to describe the etiology, pathogenesis and clinical picture of the Pagets disease, and he should also describe the treatment of Pagets disease. So we have got a clinical scenario that a 74-year-old man present to your clinic complaining of bone pain in his left thigh. He also states that his hearing has deteriorated significantly over the last 6 months. Direct questioning revealed that he has noticed an increase in his head size. So during the next hour, we will look for the answer to this problem. There are 206 bones in the body and they comprise about 12% of the body weight. When we talk about bone, we come across with the two terms, bone as an organ or bone as a tissue. When we talk about bone as an organ, we deal with the whole bone along with articular cartilage, bone marrow, accompanying adipose tissue. All structures are considered together. And when we talk about bone as a tissue, it refers to the histopathological appearance of the bone. Bone not only provide a scaffold for the muscle and body fat, it also gives mechanical support, force transmission and protection of the internal organ. It is not an inert tissue, it is an active part of the body, and it is responsible for the mineral homeostasis and lifelong hematopoiesis. The bone is divided into two parts, one is the matrix and another is the bone cells. In this picture you can see that the shaft of the bone is termed as diaphysis, while these blue areas are termed as physis or growth plate. The area just that attaches this growth plate to the diaphysis or shaft is termed as metaphysis, while end of the long bones are termed as epiphysis. Each of the bone is covered by a fibrous tissue that is termed as periosteum, and the periosteum has thick outer fibrous layer and inner cambium layer. The inner layer has a tendency to regenerate and it attaches to the underlying cortex through Sharpie's fiber that are perpendicular extensions from this periosteum. The matrix is the extracellular component of the bone and it is further divided into two parts, osteoid and minerals, the organic and inorganic part. The minerals comprises about 2/3 of the bone and osteoid about 1/3 of the bone mass. The minerals are present in the form of hydroxyapatite and they are responsible for actual hardness of the bone. They also serve as the reserve for 99% of the calcium and 85% of the phosphorus. The main protein in the bone is type 1 collagen. However, glycosaminoglycans are also present in minor quantities and other proteins are also present. The protein of the bone matrix are derived from two sources. One is the osteoblast derived protein. Osteoblast is one of the type of the bone cell, and the another group of the protein that are concentrated from the serum. The proteins that are concentrated from the serum are beta-2 microglobulin and albumin, while the osteoblast derived protein are type 1 collagen, cell adhesion protein, calcium binding proteins, proteins that are involved in mineralization, various kind of enzymes, growth factors and cytokines. These are the major head, and under these there are many proteins that are present and they are actively involved in the bone homeostasis. The osteocalcin is the protein that is measurable in the serum, and it is sensitive and specific marker of osteoblastic activity. The growth factor and cytokines, as anywhere else in the body, are also responsible for growth and maturation, differentiation and metabolism of the bone. There is another protein that is osteopontin, and this is the bone protein that contains arginine, glycine aspartate amino acid sequence, and this is recognized by integrin, that is an essential part of the extracellular matrix. As far as the types of the bone cells are concerned, there are 4 types of the bone cell, and these are osteoprogenitor cell, osteocyte, osteoblast and osteoclast. The osteoprogenitor cells are derivatives of primitive stem cell, while osteocytes are mature bone cells. The osteoblasts are bone forming cell, while the uh, osteoclasts are the exclusively involved in bone resorption or destruction of the bone. These osteoclasts are responsible for bone matrix remodeling and release of calcium in local environment. The remodeling is a continuous process. It is performed by synergistic activity of both the osteoclast and osteoblasts. The schema for the categorization of the diseases in the bone is based on the involvement of various pathways or processes that are involved in bone homeostasis. One factor is the defect in nuclear protein and transcription factor, while there are another head, and one is the defect in hormone and signal transduction mechanism. Then there are defects in extracellular structural protein, and the commonest among these rare disorders is type 1 collagen disease, that is also termed as osteogenesis imperfecta. And then there are other types of the diseases are also there, which the other groups are the diseases that are associated with defects in metabolic pathways, enzyme, ion channels and transporters, and the commonest and the important one among these is osteopetrosis or marble bone disease. The diseases that are associated with decreased bone mass is osteoporosis, that is characterized by presence of spongy and soft bone and with decreased bone mass. Then there are diseases that are caused by osteoclast dysfunction. The Pagets disease or osteitis deformans, that is the older name of this disease, come under the category of diseases caused by osteoclast dysfunction. This disorder is marked by increased and disordered but structurally unsound bone mass. So there is increased disordered bone mass, but it is structurally unsound. The abnormal bone formation of the bone tissue result in weakened and deformed bones. Though there is increased bone mass in total, but as bone is not formed properly and normally, it is deposited irregularly and not in normal fashion. So it is not going to serve one of its basic function, that is the support, the structural support, and it results in a deformed bone. There are 3 phases of the Paget disease. First is the initial osteolytic stage, that is characterized by osteoclastic activity resulting in loss of bone. As both the osteoclast and osteoblast, they work synergistically. In stage 2, due to imbalance between these two cells, there will be lacking of the mineralization, which will lead to the development of jigsaw puzzle or mosaic pattern histologically in the affected area. If you recall your concept of healing from general pathology, there will be narrowing of these spaces, and these narrowed spaces are filled with collagen, and these collagen that is less vascular, so these bone areas will be less vascularized. The third stage is also termed as quiescent stage, burnt out stage, or osteosclerotic stage. This stage comes year after the initiation of the pathologic process, and due to excessive and useless bone formation, this is more compact and more dense. On radiology, this third stage appears as cotton wool appearance. We will see the radiological pictures in upcoming slides. So, to summarize, the characteristics of this Pagets disease are that it is a disease of osteoclast. These osteoclasts show abnormal morphology and they are increased in number. There are focal areas of increased and disorganized bone turnover, and the focal bone involvement is also common. The disease can be monoosteotic also, affecting only one bone. 1% of the population of United States who have crossed 40 years of age are affected by this disease. The average age for the onset of this disease is about 70 years. 1/3 of the people who have this disease over the age of 50 years are affected, and this disease is manifested in 10% of the people over the age of 80 years. It is more common in whites and more prevalent in England, France, Austria, region of Germany, Australia, New Zealand and USA, while it is rare in native population of Scandinavia, China, Japan and Africa. For UK, its prevalence is 2.5% for men and 1.5% for females in population over the age of 55 years or older. The incidence and severity of this disease has been decreased in last 25 to 30 years in various areas. The etiology of Pagets disease is very much mysterious since Pagets identified this disease in 1887 and he labeled this disease as inflammatory in origin. Then Cohn in 1922 he proposed a vascular etiology. Rebel and Mills and Singer in early 70s labeled this disease as viral disease. During same era, Rasmussen and Bordier they thought that it is a neoplastic lesion. It was related to lead toxicities in early 90s by Spencer et al. While in late 90s Sri linked it with the genetic etiology. The current theory of etiology is genetic factor and non-genetic factor or environmental factors. It is considered that both these factors, the genetic and non-genetics, are responsible for the initiation of disease. The important non-genetic factor is the viral infection, while the genetic factor they enhance basal osteoclastogenesis and create a permissive environment for development of this disease. So regarding the genetic factors, 7 potential susceptible loci have been identified for the Pagets disease of the bone. SQSTM1 is the most important one for the development of adult Pagets disease of the bone. This is also termed as sequestrosome 1 gene. 15 to 40% of the patient with Pagets disease have at least one affected first degree relative. and 25 to 50% of the familial Pagets disease, and 5 to 15% of the sporadic cases show this characteristic sequestome 1 gene mutation in the exon 7 or 8. SQSTM1 gene or sequestome 1 gene is involved in the activation of the rank, hence subsequent nuclear factor kappa B activity that lead to increased osteoclastic activity and hence increased susceptibility to the disease. Some variants of this disease are also known. One is the juvenile Pagets disease, and the important mutation that are responsible for this Pagets disease variant, the juvenile Pagets disease, are activating rank mutations and inactivating osteoprotegrin mutations. The non-genetic factors are thought to play their role as the disease patterns show variable penetrance and it is localized to a bone or part of a bone and having its changing incidence and severity. It is also proposed that the virus plays some role in the etiology of the Pagets disease of the bone, and the clue for its viral etiology process came from the fact that the measles virus nuclear protein were present in the osteoclast nuclei. The Pagets disease is a disease due to abnormal osteoclast, and as we know, the osteoclast in the current theory of Pagets disease are affected by viral inclusion or by genetic mutation. When an osteoclast is mutated or has incorporated virus in it, it is transformed into giant osteoclast that has got a different morphology. The osteoclast that normally has 6 to 12 or up to 20 nuclei now cross 100 or more in number, and obviously viral inclusions are also seen within nuclei. This giant osteoclast then releases various osteoclastic factors. There are some osteoblastic recruitment factor and some matrix factors. The osteoblastic recruitment factor, they recruit more osteoblasts to this milieu, while the matrix factors, they are responsible for angiogenesis and fibrosis. The newly recruited osteoblasts that are recruited due to action of the osteoclastic factor that are released from the giant osteoclast, now they are responsible for further osteoclastogenesis. Hence this destructive circle continues. The osteoclasts in the Pagets disease have got distinctive morphology as well as distinct physiology. As we have discussed many times earlier, that these are characterized by presence of viral inclusion within the nuclei. That is evident by the electron microscopy, as is seen in this left photomicrograph, and also these osteoclasts physiologically are very much hypersensitive to the osteoclastogenic factor such as vitamin D and rank ligand. As the disease is characterized by various stages, so there is variation in the histologic appearance of the Pagets disease over time and across sites. The hallmark of the osteosclerotic phase is mosaic pattern, that is also termed as jigsaw puzzle-like appearance. It is produced by unusually prominent cement lines which join haphazardly oriented units of lamellar bone. Other phases of the disease have less specific features that include osteoclastic activity and and there is presence of numerous resorption pit in the lytic phase. The morphology of the osteoclast we have discussed many times earlier. They are large and have got up to hundreds of the nuclei. And these osteoclasts, they persist in mixed phase, but many of the bone surfaces, they also have got these plump osteoblasts also. First, there is replacement of marrow adjacent to the bone forming surfaces by loose connective tissue that have osteoprogenitor cells and numerous blood vessels. The woven bone is formed first and ultimately it is replaced by lamellar bone. As the mosaic pattern predominates, the cellular activity is diminished and periosseous fibrovascular tissue moves back and normal marrow restores. Finally, the end result is the coarse thickened trabeculae and soft porous cortices. These are caricature of the normal bone, and this caricature of the normal bone, it lacks structural support, hence at risk of a fracture. This is the gross specimen of the femur, the cut section of the femur. The lower arrow is showing that there is a cortical thickening and the upper arrow is pointing on coarse trabeculation. The trabeculae is derived from the Latin word that means bar or beam. So thickened beam or bar are not going to provide support to the bone, and this is due to various morphologic defects that we have already discussed. Morphological defects we have seen earlier. Now coming to the clinical picture of the Pagets disease, the clinical features like morphology are extremely variable, and mostly the disease is polyostotic, that is it involves more than one bone, and it is 85% of the cases when it is polyostotic, while in 15% of the cases it is monoostotic, means it affects only a single bone. 80% of the cases of Pagets disease are limited to axial skeleton or proximal femur. Mostly the patient is asymptomatic and the disease is diagnosed incidentally. Pain is a presenting feature and it is the result of microfracture or nerve compression. Various kinds of deformities have been reported, such as leontiasis ossea and platybasia. Leontiasis ossea is a line-like face, and platybasia is the invagination of the skull base. Also, there is constriction of the posterior fossa. The head size becomes more and so heavy that it is difficult to hold it in erect posture. There is deformity in the long bone also, and such deformity is seen in femur and tibia. There is anterior bowing of leg and femur, and due to this anterior bowing of leg and femur, there is a distortion of articular surfaces that will lead in secondary osteoarthritis. Fractures are also encountered in Pagets disease, and these fractures are of chalk stick type in long bone and vertebral compression fractures that result in spinal cord injury and in kyphosis. Neurological symptoms are also associated with this Pagets disease, and one phenomena is termed as Pagetic stele. The Pagetic stele is a condition of lightheadedness, and it is due to shunting of blood from the internal carotid artery system to the bone. The bone is highly vascularized in this Paget disease, so this highly vascularized bone can also lead to high output cardiac failure. The malignant transformation in Pagets disease is also reported, and it is sarcomatous and affect about 1% of the cases. Mostly it is associated with osteosarcoma and fibrosarcoma. The frequency of this sarcomatous transformation increases to 5 to 10%, If the patient is having polyostotic disease, giant cell tumor, giant cell reparative granuloma, extraosseous hematopoietic masses are also seen in this Pagets disease. This X-ray is showing dissolution of the cortex, and the diaphysis is increased in diameter. There is a wedge-shaped resorption of the cortex, and this resorption of the cortex is forming a flame-like structure within it, and this is termed as flame sign. And this flame sign is characteristic of early Paget disease. As the disease advances, it is radiologically characterized by cotton wool appearance, that is the presence of cortical disorganization and irregular coarse trabeculation. So this cotton wool appearance is characteristic of late Paget's disease. This X-ray is showing characteristic picture frame appearance of lumbar vertebral bodies, and this is due to thickening of the cortices and end plates. So this picture is showing the deformity of the bone that is resulting in bowing of the leg, and this bowing of the leg is frequently associated with fractures of the bone. This picture is showing the flame sign indicative of active disease, and this flame sign is a wedge-shaped lytic leading edge, and this flame progresses at the rate of about 1 cm per year longitudinally. The biochemical markers are available for the diagnosis of Paget's disease. Some are the markers of bone resorption and some are the markers of the bone formation. There is marked elevation of serum alkaline phosphatase, but serum calcium and serum phosphate are within normal limits. If there is no malignant transformation, and in this condition, this is not a life-threatening disease, and mostly the patient affected by disease and they have mild symptoms, they are treated by calcitonin and bisphosphonate that decreases bone turnover. The treatment for the Paget disease should be started for symptomatic patient and also for asymptomatic patient who are at risk at developing the development of complication of the disease. The treatment should be started for metabolically active Paget disease, and the patients having bone pain, fracture, headache, pain from Pagetic radiculopathy or arthropathy or neurologic complication, and it should be started for patients who are undergoing surgery to reduce the local blood flow and minimize operative blood loss in patients who are undergoing surgery for an active Pagetic site. It is also given to people to decrease hypercalciuria who have been immobilized, and it is also given in condition where the alkaline phosphatase is increased to reduce the complication frequency, and if this site of involvement is the weight-bearing bone areas adjacent to major joints, vertebral bodies and skull, the treatment should be started. The pharmacological agent approved for treatment of Paget disease are many, and these are the mainstay are bisphosphonates and calcitonin. These pharmacological agents are aimed to suppress the very high rates of bone resorption and decrease reduce the high rates of bone formation. So ultimately they reduce the bone turnover, and the Pagetic structural patterns such as areas of poorly mineralized woven bone are replaced by more normal cancellous or lamellar bone after the start of these treatment, and the effectiveness of the treatment can be monitored by serum formation markers such as ALP and P1NP, and urine or serum resorption marker such as N-telopeptide and C-telopeptides. The bisphosphonates are the mainstay of the pharmacological therapy of the Pagets disease, and important among these and the most effective one is zoledronic acid. That is the drug of choice, and it has got a rapid action and high efficacy of more than 90%, and the effect of the pharmacological effect of this bisphosphonate persists over months and years. This treatment is given to patient with severe disease and the patient who need more rapid normalization of the bone turnover and having the symptoms we have discussed earlier. The dose is 5 mg IV infusion over 20 minutes, but it is slower for elderly people and the people with the impairment of the renal function. It is contraindicated if the glomerular filtration rate is less than 35 ml per minute, and the side effect of this zoledronic acid is flu-like syndrome, and it is controlled by pre-treatment by acetaminophen or NSAIDs. The oral bisphosphonates are alendronate and zoledronate, and these are reserved for mild disease and the people who have got renal impairment, and they should be taken empty stomach followed by maintenance of upright posture with no food or drink or other medication for next hour. The calcitonin is reserved for the people with bisphosphonate intolerance or contraindication. This disease has got low potency, while another treatment modality is denosumab, and this is antibody to rank ligand, and it has been reported that it is responsible for reduction in alkaline phosphatase, but it is not approved for the treatment of Pagets disease. And it has got less durable and less complete effect than the bisphosphonates. So this is the summary and comparison of various bone pathologies. We will study all these diseases in detail in 4th year in the bone module. But just to give you some idea, the osteoporosis is decreased bone mass in which the calcium and phosphate are unaffected, the alkaline phosphate is variable, and parathyroid hormone is also unaffected. Osteoporosis, that is also termed as marble bone disease or brittle bone disease, and in this condition there is presence of thick and dense bones, and in this condition the calcium, phosphate and parathyroid hormone are unaffected while alkaline phosphatase is increased. The osteomalacia and rickets, that are the diseases due to abnormal or defective bone mineralization, and in these conditions there is decrease in calcium and phosphate level while there is increase in parathyroid hormone level, and the alkaline phosphatase is variable. The osteitis fibrosa cystica, that is also termed as brown tumor, and it is due to increased amount of parathyroid hormone activity. There is increased calcium and alkaline phosphatase level while the phosphate level is decreased. While in Pagets disease, the parathyroid hormone, phosphate and calcium are unaffected while the alkaline phosphatase is variable depending on the stage of the disease. The